So next, to wrap it up, I'd like to introduce my colleague and friend, Dr. Krishnamurthy, who is an associate professor of medical oncology with UNMC, and he will be discussing response adapted therapy in localized HER2 positive breast cancer. Go for it, Jaron.
Hi, everybody. Can you hear me okay?
We can hear you.
Okay. And is my screen visible well?
It is.
Okay. So, hi, everybody. I'm Jairam Krishnamurthy from the Division of Oncology Hematology. I'll be discussing response adapted therapy in localized HER2 positive breast cancer and primarily trying to cover all the recent changes that have happened in this field and what the current standard of care is. These are my disclosures. So as we know, there are these three biomarkers that we look for: estrogen, progesterone, and HER2 receptor. In these, the HER2 receptor is the one which where the initial reporting is based on immunohistochemistry, where they're looking for membranous staining and the intensity of it, which is how they report it as 0, 1+, 2+, or 3+. Typically 2+ is equivocal, and that's what gets reflex to FISH, where they try and tell us the ratio between the HER2 copy number and the centromeric portion of chromosome 17 number, so the pink ones and the green ones. And usually if that ratio is at least 2 or the HER2 copy number is 6 or more, that's considered a HER2 positive tumor. So HER2 positive tumors' basic characteristics are that it has a high risk of reoccurrence in the first 5 to 7 years, high risk for intracranial metastases, usually very chemoresponsive, and high probability of pathologic complete remission, with some studies suggesting that the rate of pathologic complete remission could be as high as 65 to 70%. And typically neoadjuvant therapy is recommended for primary tumors that are more than 2 centimeters in size or lymph node positive disease. And the size of the primary tumor criteria has probably now been moved to more than 1 centimeter. You'll see that in most cases, practitioners may be offering neoadjuvant therapy to patients for even more than 1 centimeter tumors. So these are the FDA-approved anti-HER2 drugs that we have at this time: trastuzumab, pertuzumab, trastuzumab emtansine, trastuzumab deruxtecan, tucatinib, neratinib, lapatinib, and margetuximab. Of these, only trastuzumab, pertuzumab, trastuzumab emtansine, and neratinib have a role in localized breast cancer, whereas all the others, that is trastuzumab deruxtecan, tucatinib, lapatinib, and margetuximab, are only approved at this point in advanced stage HER2 positive breast cancer. So we know that adjuvant trastuzumab improves disease-free survival and overall survival of patients with HER2 positive breast cancer. The initial trials, HERA, then the combined analysis of the NCCTG N9831 and NSABP B31, and then the BCIRG006 all showed uniformly that trastuzumab works in HER2 positive tumors and improves not only disease-free survival, but also overall survival. And we also learned from these trials that although the NCCTG N9831 and NSABP B31 did show that trastuzumab added to an anthracycline containing regimen, the A here being adriamycin or doxorubicin, that when you added trastuzumab later to the taxane arm, they improved disease-free survival and overall survival. It was BCIRG006 that kind of demonstrated that everybody does not need an anthracycline in the HER2 positive space, with this being their arm that tried to prove it with docetaxel, carboplatin, and trastuzumab compared to an anthracycline containing regimen. And at this time, with a 9-year follow-up, only 7 disease-free survivals separate the two arms. So most oncologists have moved away from using anthracyclines in HER2 positive breast cancer. And this also is important because we know that trastuzumab has a potential for cardiotoxicity, and so do anthracyclines. So definitely with the aim of not putting too much cardiotoxicity in play, we try to avoid anthracyclines. So risk factors for reoccurrence of HER2 positive early breast cancer treated with trastuzumab-based therapy. So these are some of the risk factors that have been found to be significant: larger tumors, lymph node positive tumors, and hormone receptor negative versus positive. Trastuzumab and pertuzumab are synergistic drugs. That is, they act at a different domain of the HER2 receptor, one acting on the subdomain 4, whereas other acting on subdomain 2 and preventing dimerization, which is what pertuzumab does. On the other hand, trastuzumab emtansine is an antibody drug conjugate, so it has the cytotoxic agent DM1, which is also known as maytansine, and then the HER2 targeted antibody trastuzumab, and there is a linker here. And typically the ratio between the chemotherapy and antibody here is 2.5:1. And this thioether linker is unfortunately not a cleavable linker in this, which is somewhat of a criticism of this drug, that the delivery of this cytotoxic agent is not as efficient with this drug. So the mechanism here is that the HER2 targeted antibody goes and attaches to all the HER2 positive cancer cells, internalizes the receptor, and then kind of unloads the cytotoxic agent maytansine on those cancer cells. So it's a specific delivery of a cytotoxic agent to cancer cells, and hence it doesn't cause as much systemic side effects as conventional chemotherapy does. This slide kind of shows all the current anti-HER2 drugs that we have and where they act in the on the HER2 molecule. So as I showed initially, trastuzumab acts on the subdomain 4, whereas pertuzumab on subdomain 2, and these two act synergistically. Lapatinib also kind of acts at the same site. There is another drug, neratinib, which acts at a different site. And there are different HER1, 2, 3, and 4, which is the HER family of drugs. So typically the HER4 is what neratinib acts on. There are newer drugs like pyrotinib, which are pan-HER inhibitors. That is, they try to inhibit all the HER molecules and seem to be extremely active drugs in vitro and phase 1 studies. So coming to why do we need to use neoadjuvant systemic therapy in patients with HER2 positive breast cancer? So the major advantages are to be able to reduce tumor size and increasing the chances that patient may have breast conservation surgery rather than mastectomy. And also there is potential for less axillary surgery. We can treat patients at high risk for metastatic disease with systemic therapy without any delay. It allows for patient and doctor to see if the tumor is responding and to assess pathologic response at surgery. And I'll talk about it, why it's so important. And we also know that there is no difference in survival comparing patients who have had chemotherapy before or after surgery. So this was the CT-NEO breast cancer pooled analysis that showed the association between pathologic complete remission and event-free survival. So this was a pooled analysis of 12 international clinical trials enrolling patients from January 1990 to August 2011 with the primary breast cancer treated with preoperative chemotherapy followed by surgery with a median follow-up of 3 or more years. And here, as you can see, the HER2 positive cancers in the green here have the highest rate of pathologic complete remission. And as you can see here, the event-free survival for those who achieve pathologic complete remission is definitely significantly higher with a hazard ratio of 0.48. So who should be considered for preoperative systemic therapy for HER2 positive breast cancer? Typically, it is patients who have tumors of 2 or more centimeters in size, or who are node positive regardless of hormone receptor positive status, and those should receive usually trastuzumab with pertuzumab. So the pivotal studies looking at neoadjuvant trastuzumab pertuzumab for HER2 positive breast cancer are the NEOSPHERE and the TRIFENA studies. So NEOSPHERE was a study which had 4 arms, which was trastuzumab with taxane, trastuzumab and pertuzumab with the taxane, just taxane with a taxane with pertuzumab, and just a trastuzumab pertuzumab arm with no chemotherapy. And then they had surgery, and then following this, they also received chemotherapy with trastuzumab for 1 year. On the other hand, TRIFENA was primarily a cardiac safety study, but here there were 3 arms, one with the FET chemotherapy with trastuzumab pertuzumab, followed by docetaxel trastuzumab pertuzumab for 3 cycles, the same thing, but giving not giving trastuzumab, pertuzumab with the FEC, and then the TCHP, which is docetaxel, carboplatin, trastuzumab, and pertuzumab for 6 cycles. And they were assessing pathologic complete remission assessed at surgery, and then adjuvant therapy to complete 1 year of trastuzumab. When we look at the NEOSPHERE study, it is very clear that the trastuzumab, pertuzumab, and taxane arm had the best pathologic complete remission rate of 45.8%. But what is interesting here is that even with a no chemotherapy arm of just trastuzumab and pertuzumab, a little over 1 in 6 patients did achieve a pathologic complete remission, suggesting that these drugs are extremely active in the HER2-positive space. In the trifina, again, the TCHP arm had the highest rate of pathologic complete remission among the 3 arms. And that's the reason we try to offer this to most patients with more than 2 centimeter primary tumor or lymph node positive disease, where we are offering them neoadjuvant chemotherapy and anti-HER2 therapy. So building on trastuzumab in HER2 positive breast cancer. So subsequent, of course, these trials, the NEOSPHERE and trifina, led to approval of trastuzumab and pertuzumab in combination as neoadjuvant therapy. And then subsequently, I'll talk about how they got approval in the adjuvant setting also. Neratinib got its approval as extended adjuvant therapy for patients with HER2 positive early breast cancer following adjuvant trastuzumab-based therapy, and I'll talk about how it got its approval. And then I'll also talk about the role of TDM1 going forward in the adjuvant setting. So Affinity was a trial looking at the role of pertuzumab in adjuvant therapy of HER2 positive breast cancer. So till now, what we were doing was we were giving patients neoadjuvant chemotherapy if they had large enough tumors or lymph node positive disease. And subsequently, regardless of pathologic complete remission, we were offering them trastuzumab for 1 year, including the 6 doses that they usually got before surgery. This trial was trying to assess that should patients generally receive pertuzumab also for 1 year, but this was an upfront surgery trial. There was no neoadjuvant therapy in this trial. Everybody got upfront surgery, and regardless of whether they had lymph node positive disease or not, they were randomized to 1 year of pertuzumab versus placebo, in addition to the current standard of care, which was chemotherapy followed by trastuzumab. So in these cases, what we found was that in this trial, what we found was that addition of pertuzumab did improve the disease-free survival initially at 3 years and then 6 years. But you see, the difference was not that much, although it was statistically significant. But what was impressive was that in the lymph node positive population, that difference was even more. So that difference was about 4.5% at 6 years in the lymph node positive population. But if you see in the lymph node negative population, really no difference. So that's the reason most practitioners will offer pertuzumab for 1 year in lymph node positive patients these days. So at this point, what we were doing was that anybody who received neoadjuvant chemotherapy, regardless of whether they had pathologic complete remission or not, if they had lymph node positive disease to begin with, we were offering them trastuzumab and pertuzumab for 1 year. If they were lymph node negative, we were offering them just trastuzumab. But keeping very well in mind that this was not a neoadjuvant trial, we were just extrapolating data from this trial that who needs 1 year of pertuzumab and who doesn't. And when they compared hormone receptor negative cohort with the hormone receptor positive cohort, again, everybody seemed to benefit from this. Again, as far as safety profile is concerned, pertuzumab did not seem to increase the incidence of heart failure significantly compared to just trastuzumab, but there were a few other instances of diarrhea that we saw with this trial. Coming to neratinib. Neratinib is a pan-HER tyrosine kinase inhibitor, so acts on the HER1, HER2, HER3, and HER4 family with preferential action more at the HER4. It is an irreversible inhibitor, and it has a different mechanism of action than trastuzumab and pertuzumab. Extenet was a trial which was trying to assess the role of neratinib as extended therapy after completion of 1 year of trastuzumab in HER2 positive breast cancer patients. in which in this trial, patients were randomized to 1 year of neratinib after completion of 1 year of trastuzumab therapy, and they had to be within 2 years of completion of the trastuzumab, and they were randomized to 1 year of neratinib versus placebo. And the primary endpoint was invasive disease-free survival at 2 years. And they found that there was a statistically significant improvement in disease-free survival at the 5-year mark with 90.2 versus 87.7 with a hazard ratio of 0.73. So about a 2.5% difference is what they saw in the invasive disease-free survival. Among the hormone receptor positive patients, that difference was a little more, suggesting that this would be about 4.4% difference, whereas in the hormone receptor negative, really no major difference. Among hormone receptor positive patients and less than 1 year from last dose of trastuzumab, the delta was 5.1%, whereas hormone receptor positive and less than 1 year from last dose of trastuzumab without pathologic complete remission after neoadjuvant therapy, the delta was even more at 7.4%, suggesting that this could have a role in hormone receptor positive, HER2 positive breast cancer patients who are within 1 year of completion of 1 year of trastuzumab and who did not achieve pathologic complete remission with neoadjuvant chemotherapy and anti-HER2 therapy. As far as safety is concerned, this drug, the biggest problem with this drug is diarrhea. And to the point that when FDA approved this drug, the label says that patients should be on scheduled loperamide for the first 8 weeks and going on to take about 3 times a day loperamide for the first 2 weeks, because majority of the diarrhea happened in the first 2 and up to first 8 weeks. And after that, it tapered down. There have been studies done now to kind of step up the dose of neratinib, start at a lower dose and then go up, and that seems to also help control the diarrhea. The only issue with neratinib at this point is there are a few unanswered questions. That is, what do we do with patients who received pertuzumab initially? Because when that trial was done, there was no pertuzumab. And now the other question which comes because of this trial, Catherine. So Catherine was a trial which was trying to assess. So as I said before, we were giving patients neoadjuvant chemotherapy and anti-HER2 therapy. If they achieved a pathologic complete remission, we told them, well, very well, you are likely to have a great outcome. Your risk of reoccurrence is low. I'll just give you trastuzumab with or without pertuzumab, depending on their initial lymph node status for 1 year, and they were done with their anti-HER2 therapy. And those who did not achieve pathologic complete remission, we said, well, your risk of reoccurrence is high, but unfortunately, I can't do anything different at this time. I'll still give you trastuzumab with or without pertuzumab in the adjuvant setting. So that changed in 2019 with the presentation of this trial at the San Antonio Breast Cancer Symposium and subsequent publication in the New England Journal of Medicine. So this was a trial which was trying to assess that patients who do not achieve pathologic complete remission with neoadjuvant chemotherapy and anti-HER2 therapy, they were randomized to trastuzumab emtansine, which at that time was only approved in second-line metastatic HER2-positive breast cancer. And the other arm was trastuzumab-based therapy, which was the standard of care at that time. And their primary outcome was, and of course, you know, all the characteristics were matched between the patients. 20% of the patients almost also received pertuzumab in this trial, and there were enough node negative and node positive patients. They were looking at the 3-year invasive disease-free survival, and that showed an absolute improvement of 11.3% in favor of trastuzumab emtansine, and that hence trastuzumab emtansine became the new standard of care in patients who do not achieve pathologic complete remission. And again, there was less distant reoccurrence, less locoregional reoccurrence, less contralateral breast cancer with trastuzumab emtansine in this trial. And when we look at the subgroup analysis, all subgroups benefited, even those who had microscopic disease left in the breast, that is found in the breast on surgical specimen. The only question that this trial doesn't answer is what to do with patients who have just microscopic nodal disease remaining on their surgical specimen. In those cases, typically, of course, those patients at this time with microscopic disease do undergo axillary dissection, where if we find any gross residual disease, we do offer trastuzumab emtansine. If not, usually the standard of care at this time is to continue trastuzumab-based therapy adjuvantly. Secondary endpoints were, as I said, distant reoccurrence and overall survival. Overall survival data is not yet mature, so we are waiting for more data on that. But distant reoccurrence did show that there was less chance of distant reoccurrence with the use of trastuzumab emtansine in this case. Again, as far as side effects are concerned, there were a few. We do see some platelet count drop, some liver enzyme elevation, which we commonly see with trastuzumab emtansine, but because we have enough experience in the metastatic setting treating with this drug, we are quite comfortable using it, although it was a little concerning that the discontinuation rate due to AEs was much higher with the trastuzumab emtansine compared to trastuzumab. So at this time, the AEs, the adverse events of interest with trastuzumab pertuzumab are cardiotoxicity, infusion reactions, and diarrhea, primarily with the pertuzumab, especially when we combine it with chemotherapy. Usually when we just use trastuzumab and pertuzumab adjuvantly, we don't see problems like diarrhea. Neratinib, as I said, diarrhea, and more diarrhea. And of course, being a tyrosine kinase inhibitor, it causes rash, which is a class effect of this drug. Liver toxicity and cardiac toxicity are rare, but there are some drug interactions that also have to be kept in mind. Trastuzumab emtansine, on the other hand, thrombocytopenia, elevated liver enzymes, neuropathy. We do see that in clinic also, but the rest, like liver toxicity, cardiac toxicity, are rare. But as with all anti-HER2 drugs, we usually check echocardiograms every 3 months while patients are on anti-HER2 therapy. So a proposed strategy for patients with stage 1 to 3 HER2 positive breast cancer would be those who have early stage, less than 2 centimeter lymph node negative population. There, probably it's reasonable to offer them either, of course, if they're less than 5 millimeter and lymph node negative, you could even observe them. But anybody more than that and lymph node negative and underwent upfront surgery, they could receive weekly paclitaxel and trastuzumab based on the APT study, which I didn't discuss in the interest of time, which has excellent 7-year data reported recently with a 95% overall survival and a 94% disease-free survival. Those who have, up more than 1 centimeter tumors, probably you need to assess the risk and patient preference, and you could consider neoadjuvant therapy in them, but I would probably avoid pertuzumab in those patients, since pertuzumab was primarily studied in those with more than 2 centimeter tumors, and I would rather give just TCH in those patients. And of course, those who are more than 2 centimeter or lymph node positive, regardless of primary, receive the TCHP. I did mention here ACTHP, which is also an option, but this has fallen out of favor these days because of the anthracycline here and its potential cardiotoxicity, and of course, these two drugs, the Herceptin and Perjeta, that also have that potential. If they achieve a pathologic complete remission, then probably trastuzumab with or without pertuzumab, depending on their nodal status and hormone receptor status. And you could consider neratinib in the ones who are hormone receptor positive, very well knowing that we don't know the role of neratinib in patients who receive pertuzumab. Those who have residual disease, of course, they go on to receive trastuzumab emtansine. Whether they should receive neratinib or not, we don't know. That is up for discussion on an individualized basis. That is a data-free zone, because when the neratinib trial was going on, TDM1 was not the standard of care, and we had no patients receiving pertuzumab. That's it. Thank you.
Thank you, Jerem. And thank you, Dr. Benyon, also for joining us for a quick discussion. I think we have a few minutes